Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Today we're exploring tinnitus, a frustrating, sometimes debilitating condition that affects millions of Americans and currently has no cure. It's often described as a ringing in your ears, or I call it a symphony in my ears. But as we'll learn today, the ringing doesn't come from your ears. It actually comes from your brain. We're going to meet a man who has lived with the condition for years, but he is hopeful about a new kind of treatment that tickles his tongue. Okay, that just sounds weird, but tickles his tongue and plays sounds in his ear in an effort to train his brain to ignore the ringing sound. Joining me in the studio today is Dr. Heinrich Stecker. He is a hearing and balance surgeon who is also the division director of otology and neurotology here at the University of Kansas Health System, and he's my doctor for my ringing in my ear. Also joining us is Dr. Lauren Mann. She's a neuroaudiologist and the clinical director of the neuroaudiology here at the health system. I am having trouble talking today. It's probably because my ears are ringing loudly. And we are also meeting Drew Cohn, who is joining us remotely. Drew recently traveled here from his home in Memphis, Tennessee to see Dr. Mann, specifically for that new kind of treatment mentioned already. Before we focus on that treatment, Dr. Mann, help us establish what tinnitus is and what causes it.
Tinnitus is basically just your brain lighting up for sound when there's no sound there. So I always explain it like phantom limb pain. Your brain is making a response to sound, but no sound came in the ear. And for most people, it's caused by noise exposure, but it can also be caused by certain disease processes, medication, or head injuries.
Okay, so we were just talking before the program started that, like, I have ringing in my ears, but like, if I don't have salt, I don't have ringing, or very much ringing. So that's really not tinnitus, that's Meniere's. Tell us about that difference.
Well, tinnitus is just a symptom, right? And like all symptoms, it can reflect a number of different diseases. By far the most common one is tinnitus caused by a mild, moderate, or even severe hearing loss. And oddly enough, those hearing losses can be very, very mild, but the tinnitus can be very, very loud because we're sort of programmed to pay attention to sound, even if it's not there. And that's part of the real aggravation of tinnitus, because you don't get any rest. But there's clearly inner ear diseases such as Meniere's disease, as well as problems such as acoustic neuroma, where you have benign tumors pushing on the hearing nerve that can cause ringing as well.
So the kind of Meniere's is really different than what we're talking about today with tinnitus. And this is kind of some pretty interesting stuff that you guys are developing it. So how common is tinnitus?
Recent estimates in the U.S. put it around 25%. So 1 in 10 people, it's extremely common.
That's a lot of people,
It's a lot of people.
A lot of people exposed at rock concerts, football games.
Especially in Kansas City.
Yeah, I know, it's a little bit of a problem. I do like being at Arrowhead myself. But tinnitus is not the same thing as hearing loss, so tell me how they're related.
Yeah, hearing loss itself doesn't cause tinnitus, but it can be a symptom of hearing loss if noise damage especially puts it there. They're related because we think at some level the hearing loss or damage at the ear level triggers a process in the brain, kind of like your brain trying to compensate for what's missing.
All right, so if the patient is the one who hears the noise, how do you diagnose tinnitus? How do you know about it?
You know, most tinnitus is not audible from the outside, so we really rely on the patient to describe it for us. We're working here at KU on maybe developing some different diagnostic tools that don't rely on patient report, but we usually start with a hearing test because if it's tied to hearing loss, we need to treat that underlying hearing loss first.
So Dr. Stecker, we said that you are specialized in neurotology. Did I say that right this time?
Absolutely.
Awesome. Tell us what the heck that is now. Now that I can say it, you got to tell us what that is.
So it's a separate specialty that deals with the medical and surgical treatment of hearing and balance disorders. So it's an ENT residency and then another 2 years of accredited fellowship to get that specialization.
So what do you do?
So I spend a lot of my time in the operating room. I direct the cochlear implant program, so we treat patients with very severe hearing losses as well as things like Meniere's disease, sudden vertigo episodes, and tinnitus as well. At least patients need an initial evaluation to put them in the correct sort of grouping, whether it's an inner ear problem or whether it's the more intractable kind of tinnitus that Lauren is treating.
Yeah. So now, I'm a Trekkie. Live long and prosper. Captain Kirk himself, William Shatner, says he's got tinnitus after he stood too close to a special effects explosion on set. Captain Kirk called tinnitus agonizing and tormenting because he was robbed of silence. Is tinnitus always that debilitating?
I would say only about 20 to 25% of patients come seeking treatment for their tinnitus. So for most people, it's just an annoying cicada buzz that they can ignore. Just like your nose, it's always visible, but you don't walk around seeing it, right? But 20% of people...
I think you just compared my nose to cicadas, is what I think just happened. And you looked me right as you... I know I have a good-sized nose.
I said your nose is visible.
Yeah.
But you ignore it. So for most people, we can ignore that cicada or ringing or buzzing that we hear in our head. But that 20%, we really are still trying to unlock what changes in their brain and why they can't ignore it or why it is so debilitating.
So are there effective therapies that help reduce that noise?
There are a lot of options actually to treat tinnitus, and I think that's a big misconception. I hear even from providers that refer to me that they tell patients there's nothing that can be done. But fortunately now, every day there's new developments, and for a lot of people, just treating the hearing loss, just starting with a hearing aid will treat the tinnitus. So we always encourage people to get a hearing screen, just like you get your eyes checked. Why wouldn't you get your hearing checked? Just like a regular teeth cleaning. So starting there. I think we're going to talk in a little bit too. There's a lot of options using sound to treat tinnitus. So I won't get to that yet, I guess.
So that thing with William Shatner, Captain Kirk, that whole thing about you heard a loud explosion and now he's ringing in your ears. That's not uncommon. Did it like do damage to his brain? What did it do to his brain to make him hear ringing all the time?
The really basic model of tinnitus is that reducing the input at the ear. So we damage the ear at Arrowhead because it's the loudest place on earth.
Yes,
and
it's awesome. Go Patrick, let's go Chiefs. Go ahead.
Then, instead of that, input, that sound level staying low as it goes from the ear to the brain, at the inferior colliculus in your midbrain, things get reversed. So your brain is really trying to compensate, and it actually starts being hyperactive, and that carries up through the cortex. So your brain is saying there's sound there when there wasn't.
So those of us used to grow up on AM radio because we didn't really have a lot of other radio back then, and you couldn't find a station. You just turned up the volume, and you got a static, kind of like that. Is that it?
For some people,
Yeah.
And I've heard every description on the planet. It can be ringing, buzzing. Cicada noise is really popular, especially this time of year.
It is like a kind of a buzzsaw going on. Okay, so if you turn to that great source of scientific information, Dr. Google or social media, you can find people selling all sorts of pills or supplements to help with tinnitus. Okay, any of those actually do anything?
I'll let you take it.
Nothing has ever been shown to work. So there's some herbal preparations, and there was one study in France that used one of these medications in incredibly high doses given IV. That's the only thing that had a hint of maybe working, but what you can get in pill form, probably not.
Great, a high form of something from IV just to treat that ringing in your ears. Okay. Let's talk about something that may be more effective than high doses of something and you're having to come in for an IV infusion. I take it that has to be repeated frequently. It's a new treatment device called Lenire. Dr. Mann, you were one of the first 50 doctors in the United States to provide that therapy. You brought one in as an example. Tell us how it works.
I did. I'm going to start with a really low level. I call this the DIY version. But really what we're doing with Lenire and with any kind of bimodal treatment is not just using sound to trigger the auditory path. We're using somatosensory or touch. So at a basic level, I can take something like this vibrating massage tool and have a patient listen to sound. And I'm teaching the brain, the limbic system, the fight or flight system, that this signal is really strong and important, right? Because it's coming from my ear and my skin. That will help weaken the pathway that is currently, kind of controlled by tinnitus. So that's what bimodal therapies are.
So, do you have to use that a lot? I mean, for a lot, like multiple hours a day to begin to retrain the brain?
You have to walk around with it all day long.
Oh, that's pretty cool.
No, this is really something that I recommend people use for 10 to 15 minutes a day.
Okay.
And we pair it with really specific types of sounds, really relaxing activities, not, sitting in front of a pile of laundry or working on their computer, scrolling.
Right, and not at a Chiefs game.
Not at a Chiefs game. This is really something we use for like 15-minute sessions a day. What Lenire has
cool.
done.
Can I ask you one more thing about that?
Yeah.
Like does that help with Meniere's, or only really specific for tinnitus?
Really specific for tinnitus, and there's actually a very good biologic basis for this. And lots of tinnitus patients start out with a little bit of hearing loss, and then have, for example, a painful procedure like a wisdom tooth removal, and that's what makes the tinnitus troublesome. It's the combination of activation of the fifth cranial nerve that does pain sensation on that side of your head and the hearing loss together.
Fascinating. All right, as I say on Star Trek. So tell us about some of these other devices you have.
So Lenire is the first FDA-approved bimodal tinnitus therapy device. And what they've done is taken that basic vibrating tool and beefed it up. So now we have electric stimulation in the mouth. So we're activating a different cranial nerve system, and this is, a different type of contact with the body. So patients are using this for 30-minute sessions paired with headphones that deliver a neuromodulated signal. So they've got a really specific sound that you're listening to, and it's alternating, kind of stimulating the tongue and stimulating the auditory system.
Fascinating. And is that 30 minutes, you said, once a day or twice a day or something like that?
Yeah, for most patients, it's 2 30-minute sessions. And we see results, in as little as 12 weeks, but I have been telling patients 12 weeks to 12 months.
Yeah.
I started this last summer, and I think for the majority of patients, they're getting really nice reductions in tinnitus, but they're optimistic and hopeful we can get to that full suppression. So, it varies person to person how long it takes.
Now, I think we have a video explaining what's happening inside the brain. Let's take a look. Help us explain it. Help us understand it.
So what Lenire is basically doing is trying to retrain the brain to not pay attention to that tinnitus signal in red at the top there. So when it's the loudest signal heard, it gets a lot of your limbic system, your fight or flight system's attention. So when we play a sound, we're activating the auditory nerve. It doesn't compete very well with this abnormal, this disordered pathway. When we pair sound with muscle or skin stimulation, like this tongue tip controller, the brain over time learns that this connection is not dangerous, it's not harmful, it can actually be relaxing. And this is trigeminal stimulation through the tongue. When we use 2 nerves, it's a stronger signal. So we're just basically competing with that weak tinnitus signal in the brain, creating a new connection to sound that overrides it. So pretty cool stuff.
How cool is that? Okay, well, let's talk with Drew Cohn. He came all the way from, was it Memphis? Is that right? That brought you up here? Yeah.
Yes.
And thank you for being on our program today. So, Drew, when did you first notice the tinnitus symptoms?
Probably 30 years ago, maybe 40 years ago. I had lost a little bit of hearing, and I was exposed to loud music as a child, and I'm a retired civil engineer. I was around heavy equipment in equipment rooms, and I didn't wear hearing protection.
And so it developed in you. Now, can you describe what that sound was like?
It's a for me, everyone's different, I guess. It's a high-pitched tone that never stops. And I tune it out the best I can. And when I read about the Lenire a year ago, I thought, I'm going to try. I'm going to try for a cure.
So it must have really impacted your day-to-day life that it felt so strongly you wanted to go for the Lenire.
Yes. When things are quiet and you hear all this noise, one thing I haven't discussed with Lauren, but I'm sleeping better now. Since I've been on this, I get a good night's rest, and before I was up half the night. So it was interfering, I didn't realize, with my sleep.
Oh, that's interesting. We'll come back to that point in just a moment. Now, you lived in Memphis. How did you end up finding Dr. Mann and then coming up here to see her here in Kansas City?
Okay, when the year and a half ago or so, whenever I'd go out on the web to, I think it's the American Tinnitus Association, and they would have different articles. And a year and a half ago, they had an article about Lenire, and I signed up on the Lenire site. And as providers in this country were approved and started with the Lenire, I've started contacting different providers, but I wanted an institution, an academic institution. I had another problem 7 or 8 years ago, and I liked the depth of treatment and depth of it was just a very professional experience. But I'm stumbling here, and I apologize. I wanted to go to an institution where if I wasn't a good candidate, I'd be told that. If I was a good candidate, I'd be told that. If I was a marginal candidate, I'd be told that. And that's why I chose an institution. And I called University of Kansas, and Lauren's, I guess, secretary or office, I don't know her title, said, how about February 19th? This was probably 3 months out. I said, that's a good date. And now somebody in Memphis is actually, one of the private audiologists is doing this, but this was, some 6 months, 8 months after.
Yeah.
After.
Well, listen, never worry about stumbling around. You heard me stumble over the word autologous. See, I just did it again. So thank you, and thank you for coming up to see us. Now, Drs. Mann and Stecker, are there benefits to getting this device done at an academic institution versus a private audiology clinic? I mean, I always say these brand new therapies should be an academic institution so you get the full breadth of all the knowledge and the science. But talk to us a little bit about that. Unbiased.
Well, I think it's based on the individual provider. I think probably the most important thing is providing access, because there's not enough audiologists who specialize in this around, and obviously there's tons and tons of patients. So the most important thing is getting patients treated. I do agree with you that new things should be done in an academic medical center, but I think private audiologists are perfectly qualified to do this if properly trained.
I completely agree, and Drew, you hit it right on the head. If you want to be told that you're a marginal candidate or you're a good candidate, and for you an academic institution feels like a trustworthy place, then that's great. If you have a good relationship with someone locally and they have specialized tinnitus experience or credentials, I think that's a great option too. The main thing with Lenire is just providing more clinics, getting more people trained to do this. They're adding another 100 providers by the end of the year. And here we're working hard. I'm trying to train tinnitus providers and push them out and not scare them,
Yeah, well, it looks like a very sophisticated tongue depressor is what it reminded me of when you showed it. So, Drew, how do you like using the Lenire, and how's your hearing?
I think it's a little better than it was. I've only been on this about 2.5 months, and it's going to take much longer. I understand. And you hear the different tones in the white sound. At the same time, you're getting the little stimulus on your tongue, and that feels more like a fizzy soda, if you will. It's not any strong electrical shock or anything. And I try to do 2 sessions a day. That's what we're supposed to do. I've missed. You travel, you do something, and you miss one of them or something, and so I find it pretty easy to do, but it is time consuming, and you've got to be devoted to that hour a day, 2 30-minute sessions.
You bet. Now, Dr. Mann and Stecker, in the big picture, how does this Lenire device fit into the toolbox of tinnitus treatments? And I'm curious also to hear your experience, Dr. Mann, with the patients you've done it with. How successful has it been? Let's start with that one.
Yeah, that's a great question, and that's usually the first question I get from patients. Will this work? Will this get rid of my tinnitus? And I think the right idea coming into doing any therapy like this is if you're looking for a reduction in tinnitus, if you're looking for improvement in quality of life, improvement in sleep, improvement in just how it impacts your day-to-day, it's a great tool. It is one of many tools. So it's not the only option that I use with patients. And I would say for the most part in the last year, most patients have experienced what Drew has, that they're sleeping better, they are hearing tinnitus more quietly, or they're noticing it less day to day. I have a majority of patients telling me I may go a few days before I even remember I have tinnitus now,
Awesome.
when I used to wake up and it was the first thing on my mind. So that's a pretty common experience right now. I've had a few patients go into total suppression, which boggles my mind that they could hear tinnitus for 20 years and now not hear it even if they try.
That is
and that's the
impressive.
exciting stuff.
So, do you have to use it forever, or is it just for 12 months and once you get it suppressed, you don't have to keep doing it, or what's maintenance look like?
Yeah, that's a great question. I've only been working with it not even a year, so for most of my patients, we're still in that get to the level we want to be at stage. But you know, in Europe, they've been doing this longer, and patients are having better long-term suppression. Let's say you get sick or you go to a Chiefs game and it flares up, then they're using their Lenire maybe only for a week to kind of remind the brain that we don't want to pay attention to that sound. So you're not using it indefinitely, but it is nice to have it for maintenance in the future
right.
if you need it.
Will insurance cover this, and how much does it cost to do?
Insurance doesn't cover it. It actually got FDA de novo approval because it's the only device like it in the class. So for out-of-pocket costs, patients can expect to spend anywhere from $3,000 or more to
Okay.
access one of these, depending on the clinic.
We need to get it in place with the FDA. They need to go ahead and say, yes, it's approved, and Medicare needs to be able to start paying for it, so the insurance companies start paying for it too.
If they'd pay for hearing aids, that would be a great start.
Yeah, it sure would. All right, so now what can we do to help prevent tinnitus in the first place, guys?
Hearing protection is the number one thing. So I tell all my patients that if you're exposed to a sound lawnmower level or louder, you should be wearing hearing protection.
Okay.
And actually now all of us walk around with phones and watches that can actually, they have decibel meters built in. You can see on your watch. It's on your watch.
I do. No, it goes off it
how
goes
loud
off
your
at
environment
Arrowhead.
is. Yeah.
Yeah. So, what does the future hold? Where is the research going to take us?
I think we're in an exciting time with this new category of device. It's kind of a new generation of tinnitus treatment in my mind. And even Apple today announced that they're getting in the game. So I think we're going to see a lot more wearable.
What's Apple going to do?
A sound device. So,
right.
you know, I think there'll be a lot more wearable tech. Here at KU, I'm personally working on how do we treat the hearing loss? How do we treat the underlying problem? And how do we even identify tinnitus to begin with? So I think you're going to see a lot better diagnostic tests. We're going to be able to separate out types of tinnitus, like you have Meniere's.
Yeah.
That's not the same as the patients I see on our concussion team who develop it after a head injury. So I think we need to get better at telling what it is, and then we're going to have some exciting tech, maybe even AI, to help us with treatment options.
You think about all the veterans coming from the Iraq War with the explosive devices. I bet this is a pretty big problem.
Blast injury is a whole nother category because you
Yeah.
have not only auditory injury, you have injury to the vestibular system, and you have central nervous system, so brain injury, and that combination is horrible. And then PTSD, of course, layered on,
Yeah, you bet.
on top of
all
it.
that. So this is a fascinating discussion. What do you see coming on the science side?
I think the hot topic is something called synaptopathy, which is sort of the kickoff for a lot of the noise-induced tinnitus. So it's a loss of a certain population of nerve cells that allow you to tell how sound is getting louder and allow you to hear in background noise. And there's lots of clinical trials, and we've had some of them here for both small molecules and biological therapies like gene therapy for these type of problems. But it's in the very, very early stages right now.
Yeah, hopefully that science progresses rapidly. And for those of us with Meniere's disease, really this kind of device isn't going to make a difference then, because there's a different origin of the tinnitus.
Different origin of the tinnitus. So Meniere's is a problem with balancing salt and potassium in your inner ear.
Yeah, so don't eat a Chipotle like I did
no
last
Chipotle,
night.
no pepperoni pizza.
Yeah, Chipotle equals, man, it's a symphony afterwards. It's fun, and it's funny how fast it happens. It doesn't take long to get there. So, well, all right. Well, we are here to answer your questions. Send them using the links on your screen: YouTube, Facebook's the X platform, or email the Medical News Network. We're going to next check in with Doc Hawk. Dr. Hawkeye, how are you, sir?
Hi, doing good, good.
Doc Hawk is the Assistant Chief Medical Officer and Medical Director of, the team's Medical Director of Infection Prevention and Control. I guess I'm the CMO. You know, I did not get a lot of sleep. I was working till about 1 a.m. last night.
Yeah.
You can tell today.
Yeah, well, I mean, you're always busy, so that you get any sleep is remarkable because you help keep this place running and do a great job.
Okay, so there's a Washington Post headline that included a provocative question. COVID will still be here this summer. Will anyone care? What do you think?
Yeah, I mean, I think it's a myopic question. I think it's a good question, but as we stated before, yes, for the general public, the pandemic is over. COVID doesn't impact our daily lives, but we have to remember there are groups of people where it can significantly impact their life, their morbidity, their mortality, their quality of life. So again, those people that are at risk, so higher, older age, comorbidities, especially immunosuppression, but we know we have ways to protect those people at optimum levels, and that is, number one, we have those monoclonal antibodies that can provide you protection. We know that vaccination is recommended, even a second dose. If you are over 65, you should get that second dose of updated booster if it's been more than 4 months since the last one, and of course immunosuppressed patients can get that dose as well. Have a plan if you are having symptoms, test early. If you're at home and using the antigen test, you may have to test 2 or 3 days in a row. Talk with your physician. Try to get on that oral antiviral if you can. But yes, there will be people who will be affected by this disease still this year, even this summer. But for the most part, most of the general public is really not going to give it too much thought, but we have to be mindful and sensitive to those people that will.
So there are some variants. KP2 now is one of the more prominent ones. It looks like 28.5% of the total. JN1 fell off fast from 30 now to 8. Where are we headed? Is this the same story we've seen before?
Yeah, I mean, I think it is interesting, and again, unfortunately, there is a data lag, so that is a forecast by the CDC with the data coming in a little bit later, so we are having a data lag. Again, this is a national forecast of what it will be like. We know that in the Midwest region, we still have JN1 here, more predominant than the KP2, but in California, for instance, KP2 is higher, and what California is seeing is that increase in their wastewater, and Steve, I know you've been a big proponent of monitoring wastewater as well. So, you know, we are seeing maybe some increased trends in some other states and communities. Hopefully, it will not be as high as it was this winter, which was still fairly low, but I think we just have to be mindful of that fact and kind of just monitor it day by day. But again, the new variants really don't seem to cause any different disease than any of the other past variants. We still have protection from vaccines. We still have the ability to use our antiviral drugs as well.
Yeah, just to say it out loud, the vaccines are safe, they are effective, and I don't think they cause Meniere's disease and tinnitus, do they?
They do not, although I have had some patients who've had COVID whose Meniere's has gotten worse after COVID.
After they got COVID.
So there's another reason neuroinflammation involved.
All right, so we're still following the bird flu, H5N1. There was a second human case in the U.S., Hawk.
Yeah, again, this was a case linked to dairy farms. This was a dairy worker. So the second human case really was not very ill, did have that conjunctivitis or the red eyes, basically. The initial tests were positive from the samples from the eyes, but negative from the respiratory samples. What it looked like, it was the same sort of genetic analysis that we've seen in the cows, but also in that other human case as well. Overall, not really any changes. There was one change that maybe made it more possibly adapted to mammals, as had been shown in some mice studies that had increased replication, but really no big changes making it more transmissible or able to infect humans any more than what we have seen already. So there have been some non-sustained transmission of H5N1 in the past, nothing at this point, and again, no big changes for that. We know still that the antivirals that we have currently do work on it, and we know that there are new bird flu vaccines that are being developed as well. So we are hoping to do and have that should the need arise. But overall, just have to remember the human risk is low for getting this disease at this point. Certainly, we believe that especially those dairy workers are probably going to be at highest risk. It's going to be important to take those precautions. Frequent hand washing, don't touch your eyes, your nose, your mouth. It is felt that that could be one of the ways that the 2 human cases did get infected after working directly with the cows. Try not to eat and drink around the work area as well. So there are steps that our dairy workers can take to help reduce their chance of infection.
All right, some big deals out there, but I think, like you say, hopefully this will be something we can get through and not be too concerned. Okay, we know many of you have questions. Let's head to Studio B with Alexis. Good morning.
I can't hear.
Our Facebook viewers. He would like to know, can tinnitus aggravate other things nearby, like the nerve you mentioned, or are they completely unrelated?
I'm going to say the half that I heard sounds like a you question. Can tinnitus aggravate the nerve nearby?
Well,
That's
so
Jeremy wanted to know.
that's actually a remarkably complicated question. So there are very good studies out showing that tinnitus actually can interfere with your ability to hear. It blocks out a certain amount of hearing, and depending on what type of tinnitus it is, there's also tinnitus that's generated by sounds inside the inner ear or from the little muscles in the middle ear that can interfere with hearing. There are also types of tinnitus that are associated with a disorder called superior canal dehiscence, where you can get balance disorders along with your tinnitus.
Alexis?
Stu has a question. Stu wants to know, why do I sometimes hear short-term ringing in my ears? It disappears in under a minute, but there isn't an obvious trigger.
I think that's what Dr. Stacker just described. We actually call that somatic tinnitus in the clinic. You might hear it called objective tinnitus, kind of historically. And that's really more muscle or vascular spasm, or even, the eardrum itself vibrating. And that's really common. It's kind of maybe worrisome when you have it happen to you, but those little brief periods where your hearing cuts out and you hear this high-pitched squeal, that's really normal. That's somatic. It's just a muscle spasm. And I encourage patients, if it's really bothering them, to check in with your physician, because sometimes it's caused by underlying TMJ disorders, acid reflux. It can be caused by any number of things in the head and neck. So get it looked at. And if it's really bugging you in the minute, you can make a cute little tent out of your hands and put pressure on your cheekbones. If it's really coming from that muscle process, that'll help kind of stop the spasm if it's related to muscle.
What's that old campground song? Up in the air, upside down. Like, you have to kind of put your face on. So
That's
you look
right.
like a
You
bird.
have to sing, and it will help too.
Awesome.
Sing the song.
Nobody wants me to sing. But okay, Alexis.
I never knew that with the hands. I love that. Amy asks, what was required for FDA approval of the Lenire? Do devices have to jump through as many hoops as drugs?
No, the regulations are actually less burdensome than for medications, and the Lenire is actually one of the few devices that had a placebo-controlled trial done in Europe. It really has very, very convincing data behind it, and so device approvals rely on those type of studies, and there are sort of questionnaire metrics for tinnitus distress, and then there's regulations regarding the physical safety of the electrical portions of the device.
And it's also safe to say that for a non-invasive device is a lot different than a fully invasive device in terms of approval. And this one, as a tongue depressor, essentially is a non-invasive device. So,
One more question. Marie would like to know, do you think one day you'll be able to develop a hearing aid that also works on the tongue, similar to the Lenire treatment?
Okay, team.
Oh,
Okay, so
after this, so.
yeah. Another really, really complicated question. There are devices for a very, very rare genetic disorder called neurofibromatosis 2, where you get tumors on both your hearing and balance nerve that use tongue stimulation to restore some sensation of equilibrium. And there are also old devices called vibrotactile hearing aids that are used for that very, very rare category. But nowadays, actually, we go to an implantable device that's put into the brainstem for that group of patients.
All right, fascinating. Well, this has been a great discussion, and I've learned so much from you guys. Thanks to everyone for being on the program to hear. Final thoughts before we go. Drew, thank you for A, coming all the way up from Memphis, and B, being on our program today. Final thoughts.
I'm very hopeful that I keep improving. It's just something I've been living with for so long. It's like part of you, and now I'm just really hopeful.
All right. Thank you again for being on the program. Dr. Stecker.
So if you have ringing in your ear, if you're over 50, get your hearing tested.
Okay.
Yeah.
Excellent point. Dr. Mann.
Final thought, if you have tinnitus, there are a lot of treatment options, so don't get discouraged if you hear there's nothing that we can do. There's a lot of things we can do to make it better. And if you go to Arrowhead, wear your earplugs.
All right. And I do have earplugs, especially for concert venues. Oh my God, that's really
Absolutely.
loud. Doc Hawk.
Yeah, I mean, I think this is just more things that we have to contend with and deal with to keep ourselves healthy. Just as we talk about sun protection, protection against insects and bugs, we need to also include hearing protection just for those instances that you talked about in those situations as well. It's always very important to understand the situation that you're going to be in.
All right. Well, a big thank you to all of our guests. And remember, as we always talk about, faith, hope, and science is a powerful combination. And now hear this. It's helped deliver new answers for tinnitus and hearing. We'll see you guys next week.
Thanks, Steve.
Coming up Friday on the Morning Medical Update. Stroke recovery can be daunting and it often takes years. But patients like Jamie Lorfine know that dedication, hope, and a thorough rehab plan can make all the difference. I'm Jessica Lovell on the next Morning Medical Update. How traumatic injuries can lead to strokes, even in people with no risk factors. Plus the multifaceted care required for recovery. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.